So fluid and electrolyte balance is one of the key issues in maintaining homeostasis in the body. And it also plays kind of an important role in protecting cellular function, tissue perfusion, and acid-base balance. So fluid and electrolyte balance must also be maintained for management of many other clinical conditions that we're going to kind of be talking about. The fluids in the body are primarily composed of water, but they contain a multitude of substances. So the imbalances or important electrolyte imbalances are when some of these substances are in their very low or high level states. And those include like sodium, potassium, calcium, and magnesium. So, as I mentioned, fluids are primarily composed of water, but they may contain a multitude of different substances. One group is those electrolytes, such as the sodium, potassium, magnesium, sulfite, and chloride. And the other group of substances is metabolites, which includes oxygen, carbon dioxide, and glucose. So these are substances that we, use for metabolism. That's why they're called metabolites. And then finally, the third group of substances are considered proteins. These are kind of coagulation factors, immunoglobulins, albumin, and various other hormones. So as the distribution of fluid in the body and substances is found kind of critical to maintaining what we consider intracellular and extracellular functions. Okay, and that's very pivotal to our survival. So the average male has about 42 liters of fluid of water in their body. It's about 60% of their body weight. And the body's fluids separate into two compartments. So we have our intracellular fluid volume, so the fluid that's held inside the cells, and that extracellular fluid volume. Okay? So the majority of this, or 2/3 of this, is going to be held inside the cells in that intracellular fluid volume. The remainder 1/3 is going to be should be in the extracellular fluid volume, which is kind of two spaces. That's your plasma volume, amount of volume that's in your plasma, makes up your plasma, and then your interstitial fluid volume. So that's only about 1/4 of third that volume. 75% of that 1/3 will be in that interstitial space, and then about 25% of that is going to be in the plasma. So a lot of clinical conditions that we deal with are when there's an imbalance between where this fluid is held. So more than 2/3 of the fluid is in that intercellular space, or less than 1/3 is in that interstitial space. So when that fluid shifts around and is where it's not supposed to be, that's when we have kind of clinical issues and we aren't in homeostasis anymore. So some of these clinical conditions can be like considered diarrhea. So when diarrhea happens, that is, excuse me, sorry. When diarrhea happens, this kind of can be caused by a lot of different pathogens, but it's usually associated when you have like kind of a net loss of that intercellular fluid. Okay, so the body is just losing, because you're excreting excess amounts of fluid, you're losing intercellular and extracellular fluid. Um, Diabetes insipidus is a condition where the body is unable to produce an important hormone called ADH, which is your antidiuretic hormone. So, or it's going to cause the kidneys to not respond to that hormone. So in either case, there's gonna be a decrease in free water reabsorption. Okay, so um, that's the same. The reverse happens in this syndrome. Inappropriate secretion of antidiuretic hormone. In this, water's gonna flow uh, back into that intercellular space because it's not being diuresed or kind of peed out. So diuretics are medications or hormones that are going to cause you to urinate and lose water. So diabetes, by inhibiting this antidiuretic, meaning no peeing hormone, you're going to pee a lot and then be really dehydrated. And in this syndrome for inappropriate secretion of antidiuretic hormone, you're going to have a lot of this hormone in your system, and that means you're going to retain water and not diurese it or urinate it out. Adrenal insufficiency. This happens where there's kind of a low level of aldosterone, primarily leading to a lot of sodium reabsorption. Okay, so when you reabsorb a lot of sodium, um, or uh, when you're not reabsorbing a lot of sodium, then your water is going to kind of shift into that intercellular compartment, and you're going to have more volume in that intercellular space. And uremia is often found in kind of kidney failure. This is going to cause a shift in the volume um, of intercellular to extracellular fluid. So the kidneys are kind of the primary organ that is responsible for retention and secretion of these electrolytes and fluids in a healthy individual. So this is kind of a picture from your textbook that explains kind of all of the anatomy of where these filtration and the reabsorption and uh, excretion happens. So, excuse me. So, most of all of the filtration is going to happen in these glomulars. Okay, so these are just kind of these sections here, and we have like thousands of them in our kidneys. So, the blood, an important thing to understand about kidney function is that you need to have good blood flow in order for your kidneys to function properly. So if a patient has poor blood pressure, a lot of times they're going to talk about the patient being in renal failure as well. But if you fix the blood pressure, the kidneys are going to fix as well. So I hear this a lot from families in the ICU as they get really worried. It's like, oh, their kidneys are shutting down. Their kidneys are shutting down. It's like, well, yes, their kidneys are shutting down, but it's because they're not getting perfused. So you're not having good kidney function because there's not blood going to the kidneys. So Kidneys are very, very vascular. They need blood flow. They need blood pressure in order to function properly. So if you don't have blood pressure, you have to fix that first before your kidneys are ever going to work. So, okay, so this is kind of that glomerulus area here that I was talking about. This is kind of blown up. This is where most of the filtration happens. Okay, so this is where, you know, electrolytes and water leave the blood, and supposedly, if nothing else happens, they're going to enter into urine and get excreted from the body. Okay, so slides here. So this is just a slide talking about hydrostatic and osmotic forces a little bit. So hydrostatic forces, you should think about hydrostatic forces are the forces that the volume of blood are going to apply to the inner walls of your blood vessels. So if I draw this out for you a little bit, so I lost where my pointer is going to be. Okay. So if you think about our blood vessel down here, it's a blood vessel. I'm just going to write H. The hydrostatic forces are going to be what's going to be pushing on the inside of these blood vessels. The force that's pushing on the inside of these blood vessels. Okay, so the more blood pressure I have, the more hydrostatic force, right? Because there's going to be more pressure inside that vessel pushing on the outside of that vessel, okay? So when those hydrostatic forces are kind of high, right, that's going to cause blood to be able to leave these vessels into, and that filtration to happen. Okay, so if your hydrostatic force is really high, it's going to be able to leave those blood vessels and filtration can occur. Okay, so it has to work against the fluid pressure that's in these capsules. So on the outside here, there's a pressure of 15. Okay, so it has to overcome this pressure of 15 that's on the outside of these blood vessels in the Bowman's capsule in order for it to move outside of the vessel. There's also pressures inside the fluid, okay? So we have fluids apply pressures on themselves to kind of stay together. That's an attraction of those molecules and things like that within the fluid that causes the fluid to want to stick together. So inside these vessels, there's also, I'm going to change my color. Oh no. Sorry, 1 second. Wait patiently for these colors to come up. Okay, drawing it bigger. Okay, so here's my vessel. Switch to orange. I don't know why. So let's say that hydrostatic pressure is represented by orange. This is what's making these fluid want to leave the vessels. Okay, it's this guy here. Okay, they have to work against the pressure that's on the outside of this vessel, the fluid pressure that's on the outside of this vessel, represented by the Bowman's capsule. Okay, the fluid in that Bowman's capsule, which is where the glomulars are contained. Okay, so in order for these electrolytes and these fluid molecules to leave this space, they need to have more pressure in here, just like the pressure gradients we've talked about with diffusion and breathing and everything else. There has to be more pressure in here than out here, okay? There's also one last factor where I feel like this gets a little confusing, is this osmotic forces. Okay, so I'm gonna actually color this lighter blue because it's working kind of the same way as the darker blue. Okay, so these pressures, and I'm gonna draw the arrow to the side. So these arrows are with the molecules that want these guys to kind of hold together. So imagine all of these molecules and electrolytes and water being kind of people on a boat. And the hydrostatic pressure is the amount of people. So as more and more people clamber into this boat, some of them might get pushed off and pushed out the boat into this fluid around it, right? But as people get pushed out, this osmotic force is the people in the center of the boat going, hey guys, we don't want to lose anybody to the shark infested water. So they kind of all link arms together to try to keep each other in the boat. Okay, this osmotic force, the strength of this osmotic force is what's going to try to keep these molecules inside the vessels and overcome that hydrostatic pressure that's trying to push them out into the water. So what you end up with is kind of that net filtration pressure is kind of how much this hydrostatic pressure actually wins out overall. So you can see how these things probably aren't going to change much. You know, the fluid in the Bowman's capsule is going to always kind of remain the same. The osmotic forces, this is kind of based on the concentration of those proteins, like the albumin and the other proteins within the fluid. Okay, so these two, as long as our fluid concentration stays the same, our blood concentration stays the same, and then these things are going to be kind of constant. So our blood pressure is going to have a big factor, play a big role in how much filtration happens at the kidneys. Okay. So after you have that primary round of filtration happening at the glomerulus, then you have tubular reabsorption. So this happens in kind of this area up here. You have your proximal convoluting tube over here, and then you have your loops of Henle, and these. So that's your loops of Henle, and then you have your distal convoluting tubules, and again, the anatomy, I don't really care that you know the anatomy too much, but just understand that after it goes through that first primary filtration process, then you have this reabsorption period where water, sodium, glucose, and some other substances are going to leave those tubulars and re-enter into the blood. Okay, so during that first filtration process, we might filter too much, and then we went, ooh, this kind of like, now our blood's kind of like distilled water, so we want to add a little flavor back into it. So we're going to add some sodium back in, some sugar back in, some glucose back in, some other little substances to get it back to the right mixture before it goes back out to the rest of the body. And that happens in this tubular reabsorption area. Okay. So finally, then it goes through a process of tubular secretion, which goes where we take things back out of it again. So, but this is an important distinction because what's coming back out during tubular secretion is these hydrogen and potassium ions. So this is where various mechanisms of substances are going to be kind of secreted out of the blood in these petubular capillaries. And is going to get back into the urine to be excreted from the body. So it's kind of secondary to that glomerular filtration, and very important. It's what removes the hydrogen ions, which is extremely important for acid-base regulation, and then excessive amounts of potassium from our body. And you're going to learn in a few slides that potassium is important for a lot of cellular functions. So too much or too little potassium is very dangerous to our bodies. So that blood ultimately, or our kidneys ultimately want to make kind of the perfect mixture of urine concentration and volume to help with regulation of these electrolytes and fluids in our bodies. So they do this through kind of two mechanisms. One of them is considered the countercurrent mechanism, which you don't need to necessarily know that much about. And then the other one is selective permeability. Okay, so selective permeability we're going to talk about because a little bit more in depth, because this is where that antidiuretic hormone comes into play. So your antidiuretic hormone is a hormone that's excreted by the hypothalamus, and it's controlled by baroreceptors that are located in your left atrium. So there's baroreceptors, or receptors that sense pressure in that left atrium, that are going to then send impulses to the hypothalamus to either increase or decrease ADH production. Okay, so again, diuretic means kind of, you can like associate it with, this is how much I'm going to be urinating. So if I am diuresing, I'm getting a lot of fluid or volume out of my blood and getting it excreted from my body. So I'm removing fluid from my body. So antidiuretic means I'm retaining or keeping that fluid in my body. So if these baroreceptors sense an increase in pressure, so too much pressure or related to too much volume, then they're going to send this impulse to the hypothalamus to cause a decrease in this ADH production, which means that I'm going to have a increase in urination, right, or volume loss. I'm going to be excreting more and more and more fluid to try to lower the volume that's in my blood so that these baroreceptors aren't triggered anymore by that increased pressure. In contrast, when it senses low volume or decreased pressure in that left atrium, it's going to cause an increase in this production so that I want to retain more of that fluid and not excrete it from my body as much. So that's kind of how the kidneys are going to use these hormones, or the body kind of balances the kidneys with these hormones to try to keep the right amount of fluid in our blood at all times to help us maintain a good blood pressure and perfusion. So there's several important ions that our kidneys also are responsible for regulating the concentration of. So those ions are sodium, potassium, calcium, magnesium, and phosphate. So so sodium ions are about 90% of the positively charged ions in the extracellular fluid. The amount of sodium that's in our blood directly affects the osmolarity of the fluid. So the more sodium you have in the blood, the more osmolarity you have. So the more desire, again, for that fluid to kind of stick together. That's those arms linked on the boat, right? So the kidneys control the concentration of sodium by regulating the amount of water that's in the body. If the sodium level becomes really high, then we secrete ADH, hormone or the antidiuretic hormone, and that causes us to retain that more fluid or more water volume. And it also is going to trigger something to stimulate us to feel thirsty and want to drink more. So potassium is essential for normal nerve and muscle function. Potassium is an incredibly important ion in our body. If we have potassium imbalances, if we're hypo or hyper kalemic, patients usually are going to experience a lot of muscle weakness. They might, and cardiac arrhythmias, so some serious ones too. Low potassium levels can cause VFib to happen, and high potassium levels can, widen your QRS complexes. Potassium levels also are going to change the pH of your blood. So we're going to talk about it more when we get to acid-base balance. I don't want to get real in-depth into what metabolic and respiratory acidosis, alkalosis is. But if you think about your body's pH, okay, your blood. So everybody hopefully remembers kind of the pH scale. So normal pH, or like the middle of the pH scale, is usually 7. And then you have your lower numbers down here. Oops, that looks like an 8, but it's supposed to be a 0. And then, which means more acidic. And then higher numbers up here. So I'm just going to put 10 in here, whatever, is alkalotic. Okay. So just like you learned in chemistry or whatever, you don't want things to be too acidic. You don't want things to be too alkalotic, right? Same is true of your blood. But in your blood, your pH scale, oops, that is not the right one. Your pH scale is changed a little bit. We want our blood kind of to be anywhere from 7.35 to 7.45. That's kind of the range, the pH range that we want our blood to be in. So if our blood becomes, goes below 7.35, then if our blood pH is somewhere over here, then we're considered acidotic. Okay? If it's above 7.45, then we're going to be considered alkalotic. Okay? And both have risk of cellular damage and dysfunction. So our body doesn't want us to go with the outside of this range for long periods of time. And how we regulate this is through through this secretion of hydrogen ions and carbon dioxide, right? So our body exhales acids through breathing and through secretion of urine. So our kidneys put hydrogen ions, that's going to make our blood more acidic, into our urine, which that is going to raise the pH of our blood that remains in our body. And our body can also choose to kind of breathe faster, to exhale more carbon dioxide, which will lower our blood's pH as well. We're going to talk about this a lot more when we get to acid-base regulation, so don't worry about it too much right now, but just kind of understand that we regulate this acid-base balance through our kidneys and through our lungs, and these kind of work sometimes opposite each other. I kind of use the scenario of tug of war a little bit, where our lungs are on one side pulling and our kidneys are on one side pulling, and that flag stays in the middle as long as both sides are pulling with the same effort. But if one starts pulling harder than the other, then that flag moves out of the middle, and you can end up with acid-base imbalances. So they're usually classified as either metabolic, when the kidneys or the renal system isn't working properly, or respiratory, when the respiratory system isn't working and the lungs aren't working properly. So the kidneys work to regulate that potassium levels through negative feedback controls. So if it feels like there's an excessive amount of potassium, they're gonna kind of increase the transport of potassium out through those pituitary capillaries and pass it out in the urine. Okay. And they're also gonna stimulate the adrenal cortex to increase your aldosterone level. So aldosterone stimulates the epithelial, those tubular epithelial cells to help transport that potassium ion out into the urine. So that is just going to increase that concentration of potassium in the urine and then normalize the concentration of potassium in the body fluid. Okay, so calcium, magnesium, and phosphate ions. So these are all going to kind of be round up at the end, but calcium also is and magnesium is very important for cellular function as well. So I did not try to minimize their importance by throwing them all on one slide at the end, or nor did your book want to minimize their importance by kind of grouping them all together. But elevated levels of any of these in the kind of extracellular fluid is going to cause those tubulars to decrease reabsorption. So then these are not going to be reabsorbed during that tubular reabsorption phase, and they're going to then pass out into the urine. So the opposite's going to happen if you feel low concentrations of them. So if there's low concentration, it's going to help rapidly reabsorb the substances and then return that extracellular fluid level to normal. And again, we want to maintain normal calcium, magnesium, and phosphate levels. Calcium and magnesium elevations or decreases are going to have negative impacts on some of your heart function. Actually, there's one particular arrhythmia that happens just because of magnesium, insufficient magnesium levels. Okay, so your kidneys, like I said, are very important in that acid-base balance. All of those tubulars are capable of secreting that tubular secretion of that hydrogen ions. They're going to secrete it based on how much hydrogen concentrations in the blood. So if the hydrogen concentration gets too high, that's going to make our blood very acidic, and the kidneys are going to want to excrete extra hydrogen ions to normalize that pH. So in contrast, when the blood becomes too basic or alkaline, the kidneys are going to excrete basic substances into the urine. Okay, and the basic substance that we're going to secrete is called sodium bicarbonate. And this is going to get really important when we talk about ABGs, because sodium bicarbonate, which is written like this, Na is sodium, and bicarbonate is HCO3. Sodium bicarbonate. So we know what sodium is, so I'm just going to ignore this piece here. But bicarbonate is kind of a buffer in the blood. So when the body senses a lot of acids in the blood, it is going to use kind of this sodium bicarbonate ion or molecule to buffer it, meaning that it's going to break this apart and neutralize this. This has an ability to neutralize that acid. So if I don't have enough bicarbonate in my blood can get very, very acidic. So if I have too much of it, And then my blood is going to be a little bit more alkaline or on the basic side. Yeah. Okay. So adults have kind of a normal blood volume of approximately about 5 liters. This is can increase or decrease very rarely by a few hundred milliliters. So we do a very, very good, efficient job of keeping our blood volume kind of consistent and the same. So we do this a lot. We are able to kind of shift our blood volume by either having blood shift out into the capillaries. So you have this capillary fluid shift where pressure rises. That hydrostatic pressure rises in the vessels enough to overcome the external forces that are keeping blood in the vessel, and then fluid's going to leak out in that tissue space. Um, uh, and then that causes that blood volume to kind of decrease back to normal. So this is kind of what happens. This is kind of the mechanism that happens actually with um, congestive heart failure, right? If there's too much blood in the pulmonary capillary beds, then you have that capillary fluid shift out into the interstitial spaces and into the alveoli, and then you end up with pulmonary edema. So when this happens too much, then you get that edema and the issues that's caused there. And then when that blood volume falls, that capillary pressure decreases, and then fluid from that interstitial space should get reabsorbed into the blood. Um, so obviously there's limits to the system because tissues can't like expand indefinitely. Okay. So you if blood volume gets way too high, the tissues aren't going to be able to take on all of it. The renal system is, where as that blood volume increases, that glomerular pressure in those kidneys is going to rise and cause more filtration, and more volume of urine is going to increase. So that's kind of how the um, renal system works. So that also works with just the pressures in the kidneys to increase that glomerular filtration, but also as that increased blood volume stretches that atria of the heart. Again, they have those receptors that baroreceptors and volume receptors there that cause more blood to want to go to the kidneys. So the body is kind of fascinating in the fact that it has lots of abilities to balance itself out. So as it senses higher blood volumes in that left atria, it's going to route more of the blood or more perfusion to the kidneys to hopefully have more excretion of volume out through urine. God. So renal failure happens in, you know, from like congenital disorders, infections, obstructive disorders, inflammation, immune responses, and neoplasms or like cancer. So it can kind of happen from a couple different causes. So a certain percentage of babies, about 10% of babies, are born with, congenital defects or kind of malformations of the kidney renal system. That are going to cause issues. So those are your congenital disorders. Actually, interestingly enough, your lungs and your kidneys, which I think the body is a beautifully constructed mechanism because your kidneys and your lungs, which are responsible for acid base regulation, actually form at the same time during embryonic development. So as your kidneys are forming, your lungs are forming. So a lot of times when you have kids have congenital malformations of the kidneys, sometimes they have lung issues as well. Like if they have one doesn't form right, the other one's not forming right as well. So we've seen that in the NICU a lot, where we have kids that come out with kidney issues, but then also have like hypoplastic lung disease and things like that. So that's unfortunate for the kid, but kind of interesting in how these things are developing in the body or during embryonic development. Infections, UTIs are kind of extremely common. So 20% of women develop UTIs sometime in their lives. So that can cause, if you have a UTI, that can cause severe damage to your kidneys if it goes untreated. What we mean by kind of obstructive disorders is anything that's going to kind of obstruct the urinary flow. So there could be like kidney stones. Normal pregnancy is going to obstruct your urinary flow. Different types of inflections and inflammation, and neurological disorders. All of those can kind of obstruct your flow of your urine and then cause issues with it. Back pressure in the kidneys, inflammation and immune responses. So, other different types of drugs, radiation, chemicals can cause inflammation, and then that can cause kind of nephritis of that glomerular and bleed and uh, issues with kind of urination and kidney failure, renal failure. And then those neoplasms, like I said, are cancer. So there's kidney cancer is not really super common. It's about 1 to 2% of all cancers. It's very rare in adults. So most of the cases are actually found in children. So kidney disorders are kind of further classified as kind of the anatomic portion of the system that's kind of responsible for the decline. So we have like pre-renal, renal, and post-renal kidney disorders. That's what they kind of consider them as. So pre-renal being, anything that's going to impair the blood flow to the kidneys. Renal conditions, that's anything that's obstructing the blood flow through the kidneys. And then post-renal is anything that's obstructing the urinary tract between kind of the kidneys and then it exiting the body. Excuse me. So, a lot of times, like I said, chronic renal failure and cardiopulmonary problems can go hand in hand. Um, so, in patients with like acute renal failure or sudden renal failure, the the body's ability to eliminate all of those wastes or water or electrolytes is impaired. So the water retention is going to cause kind of peripheral edema and that pulmonary congestion that we talked about, like you see in congestive heart failure. Um, So, and in like end stage renal failure, like every single part of the body is going to be affected because of this buildup of these um, wastes. So, typically, if you have renal failure, you're going to see patients have hypertension and the edema. They're going to experience that metabolic acidosis because the kidneys are going to not be able to excrete those hydrogen ions. You're going to have the renal acid base disturbances caused by like electrolyte anomaly abnormalities. So really to do with your chloride and your potassium. So your chloride can lead to kind of that acid-base disturbance in the renal system. Um, um, and then anemia um, happens a lot because the kidneys are the primary source for this I can't ever say it, erythropium, which is the hormone that stimulates, the hormone that stimulates red blood cell production. So if your kidneys aren't working, it's not going to secrete this hormone, and then you're not going to want to produce as many red blood cells. You're going to have increased bleeding because of platelet abnormalities. Um, and then that hypertension is going to lead to a lot of cardiovascular problems. So, as that extracellular fluid increases because of excessive amounts of sodium and water, that's going to have your edema. Your heart's not going to be able to process all that volume, so it's going to go into kind of congestive heart failure. And then you can have pericarditis occurring. Okay, so typically we want our fluid balance to be about um, excuse me. We typically want our fluid balance to be about 50 to 60 milliliters per hour. So if you think about intake and output, fluids come into the body through like IVs. We can give our patients fluid through IVs. We can give them oral fluids. We can give them fluids through an NG tube. So it's anything that they ingest or get intravenously through an IV. Oliguria is a term that we use for low urine output. So this is a good indication of fluid deficiency and may occur as a result of like decreased renal perfusion or that renal failure, decreased fluid intake, or decreased cardiac output. So, like I said, normal urine should be about 50 to 60 milliliters per hour. And if urine output falls below 20 milliliters per hour, or 400 milliliters in 24 hours, or 160 milliliters in 8 hours, it indicates fluid deficiency. So, oliguria may be seen in, after any bleeding or diarrhea or renal failure. A lot of times you see it in shock. Sometimes the patients have deep comas or any type of issue that would cause decreased perfusion to the kidney or decreased kidney function. Sorry. We also see a decrease in urine output a lot of times with just because the patients are on mechanical ventilation. So during positive pressure ventilation, your cardiac output is going to be potentially reduced. Okay. And again, if you think about my little drawing that I'm always drawing, you have your right heart, your left heart, and in between your lungs. And your left heart's going to bring blood we'll add our kidney beans in here. Oh, that's bad. All right, so blood is supposed to come back here to the right heart. That's the way the blood is supposed to go. Okay, so blood is supposed to return to the right side of the heart here, okay? But the right side of the heart is really sandwiched. Your heart is sandwiched between your lungs. So when I'm using positive pressure ventilation, this is the other one I always draw. When I'm using positive pressure ventilation, instead of having negative pressure opening my lungs up, I'm using positive pressure. So there's all this excessive amounts of pressure in this thoracic cavity. Okay, so when I have to put a patient on a ventilator, there's all this excessive amounts of positive pressure in this thoracic cavity, meaning that there's more pressure on the outside of the right side of the heart, meaning that there's less volume, less preload, less venous return coming into the heart. So all this positive pressure around the right side of the heart is going to decrease venous return. Okay? Or can potentially decrease venous return. This doesn't happen in everybody, but so I'm going to have that decreased venous return, which is then ultimately going to decrease my cardiac output. Okay. So my cardiac output is ultimately decreased, and thus my renal perfusion is decreased. Okay. So urine output is decreased because of that hyperperfusion of the kidneys. Okay, so that's kind of the first mechanism that happens with this. So let me use this really quick. The second mechanism is an increase in that antidiuretic hormone. So your mechanical ventilation is also going to kind of reduce your urine output as a result of increasing that antidiuretic hormone. So when you're on mechanical ventilator, you're going to stimulate more production of that antidiuretic hormone, meaning that we're going to retain more volume. And you're also going to reduce something called your atrial natriuretic factor, which regulates your your sodium, and the end result of these three changes are going to decrease the fluid output and cause fluid retention. Okay, so because of this, then you really want to monitor when your patient's on a mechanical ventilator their fluid levels, that intake and the output. Okay. All right. So that concludes this lecture here. If you have any questions, please let me know. There is a worksheet that went along with this with a few questions for you to answer that will be due on Sunday.